Why do so many people wake up at night?
And naturally, sleep doctors get to complain about their own sleep, to their fellows if that's what they want to do.
Would you say the majority of the reason then that adults wake up in the middle of the night is related to airway issues?
Could you tell us why you wake up? And it turned out very few people had anything to offer.
You noticed a difference when you put that appliance in because it shifted your jaw?
And beginning to put together some research studies on nightmares and insomnia in PTSD patients.
Alcohol consumption before bed is like a no-no, right? That destroys sleep, does it not?
So that means that if you treat your sleep disordered breathing, you have an excellent chance that you will not wake up to go to the bathroom.
We are back for another episode. Welcome. Thanks for joining us. And always check out what we're up to at Mikeseapodcast.com. We really appreciate your support. We appreciate all of you subscribing, for checking out our stuff, for the positive reviews, and for dropping us comments as well. We're on YouTube. We're on Apple. We're on Spotify. You can also catch us on Rumble, and basically wherever you get your podcasts. And always check out what we're doing and our latest episode at Mikeseapodcast.com. We also have a newsletter mailing list coming out in the near future. And if you'd like to contact us, you can hit us up at mikeseapodcast@gmail.com to get signed up for that. We're always looking for ways to connect with you guys, and we just appreciate your support and being a part of this podcast. And our guest today is going to discuss a very prevalent issue today. His name is Dr. Barry Krakow. If you suffer from sleep issues like so many people do, I hope you'll appreciate this episode. He is a board-certified internist and sleep medicine specialist, internationally recognized for the discovery and implementation of the most advanced approaches to solving the disabling sleep problems experienced in mental illness. There's a serious connection there, and we're going to get into some of that today. He's the author of the new book, Life-Saving Sleep, New Horizons in Mental Health Treatment. Please welcome Dr. Barry Krakow. Barry, thanks for being here today.
Thanks very much, Mike. I hope that we don't put anybody to sleep today.
Now, that might be a blessing to some people that are watching.
Could be.
So you've done some interesting work. We were talking a little bit off camera about the different things that I was reading on your discoveries and the things that you've been working on. And there's a lot there, and always appreciate sleep medicine because there's so much to it, and so many people are dealing with sleep issues today. And I want to start with a really, really basic question. Why do so many people wake up at night?
It's a great starting point because it speaks to the problem, as you've just asked the question. Why is it that so many people haven't figured that question out? In other words, it's so common, you'd go, well, shouldn't you be able to have a guess as to what's going on? And in fact, we did a research project on that very question. And we asked people, could you tell us why you wake up? And it turned out very few people had anything to offer other than, I don't know, stress, or I wake up and I pee, something like that.
Yeah.
Occasionally somebody would say bad dream. So then we said, well, let us ask you some things. So we threw out 20 items. We said, well, what about the temperature? What about noise? And so they started saying, oh yeah, well, it's that. So we finished that interview, and after they'd listened to all these different ideas as possibilities, we then said, okay, well, now what do you think? Why do you wake up at night? The most common answer was, I don't know. So we put them in a sleep lab. And these, by the way, were people who suffered from the condition called chronic insomnia, where this waking up at night was happening a lot, very, very common. And we put them in the sleep lab and said, well, in the sleep lab, we might be able to find out why you're not sleeping or what's waking you up. And 90% of the time, when they had an awakening, you could see on the sleep study something was wrong with their breathing. They were getting less air while they were trying to sleep. And the body's natural response is to wake a person up Because why? You want to wake up and breathe. You want to wake up and
Yeah.
have more oxygen. The problem
Mhm.
is that everything I just described occurs while you're sleeping. So when you wake up, unless you woke up choking and gasping and struggling for air, you're not going to say you woke up because of a breathing problem. You're going to say, I woke up, and you're going to go, I started thinking about my job. I started thinking about my relationships. And then you tie that back to, oh, that must have awakened me. So you
Mhm.
see by your question, it's a fascinating one because people have actually used that experience to give themselves the wrong answer as to what's waking them up.
So in the sleep lab, you measured this in what way? You're obviously monitoring everybody's vitals. Is it just is there a noticeable drop in O2 levels? Like, how are
Absolutely.
you catching this?
So in sleep medicine, and this is very controversial, that the field of sleep medicine has been going through these phases. It started in the 1960s or 70s when they discovered sleep apnea. And they said, oh, sleep apnea, you stop breathing. Okay, well, that looks pretty bad. Let's do something about it. And somebody, took a vacuum cleaner. Colin Sullivan took a vacuum cleaner, reversed the polarity on it, and put it on somebody's face and made a CPAP. That's the discovery of CPAP. It started the
Mhm.
whole field of sleep medicine. That's the only reason you have sleep centers now. Because in the 1980s, CPAP was discovered, and all these people went into it who knew very little about insomnia, by the way. They knew about the pulmonary lung condition, it's really the upper airway, of sleep apnea. Along came the 1990s, and researchers said, I see that stopping breathing is not good. We all agree on that. But it turns out
Mhm.
that the volume of air that you get should be what would be called normal. Well, is there a place between normal and not breathing? And it turns out there is. And that place was called hypopnea. And hypopnea just means, well, 50% of your air volume is gone. Now, why would that happen? It happens because your throat is collapsing. Okay? Your throat is actually getting narrower so less air can come through. That's called airway collapsibility. And then the final stage, the one that's the trickiest, the most controversial, is that even after you drop your air 50%, that clearly needs to be treated. Everybody in the field of sleep medicine, all the insurance companies say, oh, treat the apneas, treat the hypopneas. But there's a third breathing event. That's what I call it now, the third breathing event. And what happens is the airflow only drops out 10%, 20%, 25%. But what do you see with that? You see a change in the brain. In other words, even, and I like to say to people, put your hands around your throat and choke yourself 10%. or choke yourself, 25%.
Yeah.
Like, does that bother you? Do you think you would enjoy having that happen to your throat all night long?
I don't even like the feeling of something pressing my throat.
Exactly,
Yeah.
exactly.
Mhm.
So it turns out this third breathing event isn't accepted by many insurance companies. And unfortunately, too many doctors listen to the insurance companies and think they can ignore that third breathing event. So when we did that research study, in this group of 20 specific patients we looked at, they had over 500 total awakenings, thousands more arousals. Awakening means something longer and arousal is something shorter. Half of these events were the third breathing event. They still had 50% of their breathing events apneas or hypopneas, but that third breathing event was 50% of them. And when you look in the cases of chronic insomnia patients who suffer from sleep disordered breathing, which by the way is an astronomical number, and we need to go over that so people really understand, because we're talking about a ton of people have this condition and don't believe it, don't know how to go about dealing with it. I'm going to give you some ideas about how they can work with that just from listening to this show,
Mhm.
what they can do. And so you've got to appreciate that just because you don't experience it because you're asleep, it really is happening. And once you learn about this, even before you go get a sleep study, you can do things to help yourself. And once you start doing that and you realize that it works, you go, I'm all in. This is really the reason I've been having this problem for so long. And I had it too myself, and still use a CPAP machine, actually a very advanced PAP machine we'll talk about later.
Okay, so would you say the majority of the reason then that adults wake up in the middle of the night is related to airway issues?
So that's a great question, because we have to distinguish between people who occasionally wake up, because there's a whole bunch of people that occasionally wake up, and those people could be waking up for a lot of different reasons, although I'm going to come back to one you're going to love about trips to the bathroom, which is just amazing. But let's put it out there for the people with chronic insomnia, because those people are a very large cohort in society. At least 11% of all adults, at least in Western civilization, have chronic insomnia. A huge proportion of those patients have tried prescription sleeping pills, over-the-counter pills. You know what their number one treatment is? Can you guess?
Melatonin?
Not even close. Alcohol.
Really?
Alcohol.
Oh, wow.
So people, alcoholism actually has been shown to be a leading cause of treatment of insomnia, to the point that 1/3 of alcoholics report they started drinking to help them sleep or to eradicate their nightmares. Do you realize how large that is? All because of these sleep problems, you have that abundant number of people starting on abusive relationships with drinking. I'm not against alcohol.
And you correct me.
Go ahead.
Yeah, I mean neither. And you correct me if I'm wrong, but alcohol consumption before bed is like a no-no, right? That destroys sleep,
Well,
does
that's
it
where
not?
it's so confusing. If you drink alcohol close to bedtime, you can not only put yourself to sleep, you can put yourself into deep sleep. So you're going, wait a second. Well, I thought you said alcohol is bad. Okay, well, here's the problem. The alcohol wears off, and then you start having this up and down fragmentation all night long that seems to be triggered by the now absence of alcohol in somebody who's chronically using it. There are people, by the way, who probably do drink 1 or 2 drinks in the evening or even near bedtime and probably have a very good response to it. And that's great for them. So I'm not here to say, oh, you can't do that. I'm saying it's fascinating how many people who have become alcoholics, the research is there. 1/3 have said, I'm trying to get rid of insomnia, or I'm trying to get rid of disturbing dreams. Very, very active attempt by the use of that substance. But my point is, there's so many people out there that have this problem. They've tried over-the-counter supplements. They've tried weed. They've tried whatever it happens to be. And they're not thinking about the possibility of something going on in their airway. But the other group you're talking about, that's where it gets really tricky. What if you've got somebody who has no insomnia? They just wake up a bunch and they roll over and do what? They go right back to sleep. Question is that a problem? Well, it may not be. What if they roll over, go back to sleep, and they get up in the morning and they feel great? Then why does it matter? It doesn't. However, here's the kicker that everybody goes wild over. Name for me, if you would, off the top of your head, whatever you think are some of the biggest reasons somebody wakes up at night to use the bathroom to urinate.
Well, I've read different things. I'm going to say electrolyte imbalance, maybe, high sodium, low potassium, or vice versa. What
How about
else?
simple things like drinking too much water?
Blood sugar. Okay, yeah, sure. Drinking too much water,
high
blood sugar levels.
obviously taking a diuretic. Another one could be, as you get older, prostate problems, bladder problems.
Right.
All these things are thought to be incredibly common. Probably not the number one reason. When I tell you that the number one reason is probably sleep disordered breathing, you'd say, wait, what is this guy smoking? So follow me on the physiology. By the way, you can see a 5-minute video of what I'm describing right now in 30 seconds on my website, barrykrakowmd.com. When you struggle to breathe, you actually go through a whole cardiovascular process in your body that triggers your right atrium to release its own diuretic into the bloodstream, telling the kidneys, pass more water, make more urine. So that means that if you treat your sleep disordered breathing, you have an excellent chance that you will not wake up to go to the bathroom.
Wow, that's crazy.
Totally nuts. When I learned that, and I'll tell you the story, this is a TEDx talk I did some years ago, where I had been in the field of nightmare treatment research and beginning to put together some research studies on nightmares and insomnia in PTSD patients. So that had been my whole focus. And during that time, we were beginning to see that a lot of PTSD patients had sleep apnea. And so that itself was interesting, but I myself during that period was having a little bit of insomnia. So I was having I was in a conference with a bunch of sleep doctors. And naturally, sleep doctors get to complain about their own sleep, to their fellows if that's what they want to do. And this dentist pulled me aside, a friend and colleague of mine, he's passed now, Dr. Thomas Mead. He was the inventor of one of the first dental devices that you put in the mouth to hold the jaw forward to treat sleep disordered breathing. So he walks me into the kitchen of this place that we're in by the conference room. He takes out this piece of plastic, puts it in a hot water, puts it in the microwave, takes it out, hands it to me, says, "Put it in your mouth, Barry, and clench down." So I then hand it back to him. He shaves it a little bit. He puts it in my mouth again. He goes like this. Is it comfortable? I said, "Yeah." He said, "Well, you sleep with this now, and you tell me what happens."
Yeah.
So prior to that, for 2 or 3 years, I had been suffering from insomnia and waking up at night to use the bathroom to pee. I put that in the very first night. I slept 7 straight hours, did not wake up for any reason, did not wake up to urinate, had no trouble falling asleep, had no awakenings that I had to fall back to sleep. And when I woke up, I felt great. And I said, aha, I've been missing something. I have been missing something. I have this same condition I'm investigating in the other people who've been part of our research studies. And that particular personal experience led me down the path to realize that maybe more people with chronic insomnia might have this condition. And of course, nocturia, which is the name for, waking up at night to use the bathroom, is a condition that is not discussed in the scientific literature, urology journals, primary care medicine, as being related to sleep apnea. So now again, we have this pearl. People can hear this and go, well, that just couldn't be true. My doctor told me it was my prostate. You know how many people I've seen with prostate problems who we saw in a sleep lab have sleep apnea, treated them with a PAP machine, and their trips to the bathroom either decreased or went away? The number is over 1,000. That's how common this is. So the question is, why does medicine not disseminate this information? And that's the beauty of podcasts and the internet, that now we can actually reach people and they can become, coached up and educated to a level of like, wow, look what you can do with all this information. I really understand now what's going on with my sleep.
That is fascinating. So I'm a bit of a biology, physiology nut. So I want to ask a specific question to what you just shared with us, and that is that is it the atria that sends a signal to the kidney to dump water?
It releases the diuretic atrial natriuretic peptide, and the reason is that when you are struggling to breathe, that means your chest cavity is working overtime to pull air in. Well, that increasingly negative intrathoracic pressure inside your chest cavity is now pushing on the venous system, and that forces blood back into that right atrium at a speed or a volume more than it should be, and the right atrium detects it and doesn't realize it's a false fluid overload signal. So the right atrium feels, so to speak, overloaded with fluid. So it says, I got to protect the heart. I better release the
Yeah.
diuretic. And that's what it does.
And so when you put that appliance in, we've talked about dental appliances a little bit with my good friend Dr. Ingo Mon, who's a Scottsdale area dentist who has done a ton of work on airway medicine and has developed the use of appliances for people that have airway issues. You noticed a difference when you put that appliance in because it shifted your jaw in a different way? Is that the one that you used?
Right.
I've seen that
They're
one. Is
called
that the same one?
mandibular advancement devices, and they do
Hmm.
allow for the airway to be larger. In fact, a simple test anybody can do is to put their bottom teeth in front of their upper teeth, like that, and then do some breathing through their nose. And most people will notice, most people with breathing disorders will notice that they can breathe better. It's a simple test to say, well, you're probably a good candidate. Now, the tricky thing about the dental devices, which, by the way, I am a strong advocate for, it's a great, as I'll call it, starter device for a lot of people,
Okay.
but it's really better for the treatment of the apneas and the hypopneas, and it's not consistently effective in treating this third breathing event. And that's a controversy amongst the dentists because, they don't want to feel like, they're giving somebody something that is, not the best treatment. Yet again, they've had to deal with so many CPAP failure cases. That's why the dental
Hmm.
industry in this area has exploded. And that's great because CPAP isn't a great device. It fails many, many people. But the dental device is not always so consistently efficacious in treating the third breathing event. I used a dental device for 4 years, and then I switched over to PAP and was able through that experience to realize why PAP is actually a more efficacious treatment that will actually get the third breathing event. Many dentists don't appreciate this, but again, I'm not knocking them. I love to see patients start treatment on dental devices when that patient is like, I will never use CPAP, or they failed CPAP. It's horrible. It's traumatizing, by the way, to try to use a CPAP device and have, worse sleep, ripping it off in the middle of the night, having claustrophobia, panic attacks. CPAP has a horrible reputation, and that's why so many people are looking for alternatives. And the dental device is a very good alternative with the caveat that you have to know you're not likely to treat all the breathing events like you can with the advanced PAP machines that we can talk about later. But we also have to
Hmm.
focus on the fact that your nasal breathing is really where so much of the action is. And that's also another problem in the field of sleep medicine, in my experience, because I'm stunned by the number of people who come to see me in my coaching services. Same thing on my website, barrycrakowmd.com. I do a sleep coaching service. And more than half the
Hmm.
patients who come to me, their doctors have not spoken to them at all about what they can do to perfect nasal breathing, because that is so instrumental in the entire process of the sleep disorder breathing pathophysiology as well as its treatment.
Hmm. Now the airway specialists, like my friend that I mentioned, and there's many others, are big advocates for nasal breathing. Is that now? I'm not totally. I know what PAP is, but I've never really seen one in
Right.
person. I've seen videos. Does a PAP system encourage nasal breathing,
Unequivocally.
or is it through the mouth? It
Unequivocally, yeah.
does. Okay, and that's optimal because we make nitrous oxide breathing through the nose, right? Breathing is very unhealthy. Is that correct?
Absolutely. Absolutely. We are designed to be able to breathe through the nose, and whatever all the attributes are of nasal breathing, I have certainly not studied them all myself. It's simply a function that I have seen in my clinical practice, that if you do not perfect your nasal breathing and eliminate the signs of obstruction, inflammation, friction, whatever could be going on in there, then your chances of getting a good response to a dental device, to a PAP device, are very limited, very limited.
Hmm. Does PAP, you said that you use PAP yourself, and I appreciate you sharing that. Does PAP, is it something where you have to turn up the pressure more and more? Is it something that's adaptive and that you need more of? Or like, how does PAP work? Can people be on that long term, and does that have good outcomes? What's your understanding of all this?
Eventually, they will invent much more sophisticated technologies to treat sleep disordered breathing. Right now, the Cadillac device, the one that I use, actually has the name Adaptive Servo Ventilation, ASV. It's a bi-level device. So just a brief history of clinical pearls that people should hear. CPAP is a device that's good for about 1 out of 3 people. That's it in my clinical experience. Yeah.
Really?
CPAP is fixed
Wow.
pressure. You breathe in CPAP one pressure, you breathe out one pressure. CPAP causes claustrophobia, it causes pressure intolerance, it causes anxiety. It's really a horrible device for a person who can't get a good response to it or who can't adapt to it. It's a great
Mhm.
device for somebody who's using it, which I said is about 1 out of 3 people. We learned in 2005 that CPAP causes this expiratory pressure intolerance. People don't like breathing out against it. So we switched everybody over to bi-level. And bi-level means you breathe in a higher pressure and you breathe out a lower pressure, and breathe out.
So the pressure comes down on the
Exactly,
exhale? Is
exactly.
that how
Right.
it
In
works? Just so I
1990,
understand?
Dr.
Okay.
Mark
Okay.
Sanders discovered you only need this pressure up and then this pressure down for when you're breathing out. So it's much more comfortable. No claustrophobia, no panic attacks, no anxiety. You would think it's a no-brainer. To this day, most people have to fight with a sleep doctor to get a bi-level device. When if they would have just given the bi-level devices, they would see the number of people using PAP therapy to skyrocket. We discovered this because we had the great fortune of working with mental health cohorts, and we got to see them complaining about CPAP, and we had to respond. We said, well, what are we going to do? How are we going to help them? And so bi-level helped them. And so from 2005 on, that's what we did. By 2010, 2/3 of our patients were on auto bi-level. It's an auto adjusting technology. So it's adapting all night long,
Mhm.
adapting every 3 breaths. And the other third were on the ASV device. I've been on ASV for about 15 years. I think it is a device, literally, that is so advanced technologically that every single person who goes to get a test and gets diagnosed should start with ASV. Why? Because if they did, 90 to 95% of them would use the device, and they'd use it all night long, and they would be ecstatic about the way they're sleeping. But that kind of logic does not ever diffuse its way into medical or even in some ways manufacturing circles to realize there's an opportunity to make America healthy again truly by giving people the
Yeah.
sleep they need with a device that actually works. And this is just one of these bureaucratic nightmares that's been going on now for decades of not recognizing CPAP is not a particularly effective device for the largest majority of people.
Now, why do people have to fight with their doctors to get an AS? It's an ASV machine is the preferred one that
Right.
you're
Because
speaking
if you
of,
look,
Barry?
oh,
And is that an
yeah,
insurance
it's
thing,
an
or
insurance
what's
thing.
the
It's a
conflict?
scientific research thing. It's called the bane of modern medicine, which is called consensus medicine. Consensus medicine means a bunch of experts sat around a table and said, well, we think we should all, okay, we all agree. Good. That's what medicine is now. I'm not at all criticizing those experts. They're very good. They're very good doctors. And they all write in their their consensus statements. But individual circumstances necessitate varying from these consensus guidelines when necessary. Well, guess what? Most sleep doctors don't read that line. Seriously, they don't. Most sleep doctors think CPAP works for everybody. And if somebody can't get used to it, you know what they say to them? Try harder. Just use it longer. Just try again. The thousands of people who've told me these stories is maddening to know how much suffering these people have had to go through. And when they came to our center, we said, all right, we're going to put you in the lab. We're going to put you on CPAP, and we're going to see exactly how you're not responding. And we're going to use that information, and we're going to report that on your study, and we're going to write a prescription. And in 15 years, from 2000, well, now 20 years, but the 15 years we practiced medicine in Albuquerque, New Mexico, we never had an insurance rejection. We explained, in fact, before we even wrote the script, we reached out to every medical director we could in 2005, 2006, 2007, Medicare, United, Cigna, Aetna, Blue Cross. We spoke to medical directors and we said, this CPAP nonsense is crazy. We found something that works better called bilevel. Here's why. And you're going to be seeing a lot of prescriptions coming from us for this. Is that okay? Are you good with that? Not only was no one objecting, but every one of these medical directors said, that's a great idea. Yeah, CPAP failure is a really bad thing. We'd love to see something better. But to this day now in modern times, so-called modern times, 21st century, here we are in 2025, you have to fight with your doctor to get that prescription. And the insurance companies now, most of them will not approve a bilevel unless that doctor has given a conclusive reason to switch. And because the doctors are not looking at it that way, they go, well, gosh, I don't know why you can't use CPAP, Mr. Jones. What's wrong with you, Mr. Jones? I can't solve that problem. This is a horrible thing to say, but that's the conversations that these patients are having to undergo. It's very demeaning. It's very shameful because they're thinking, well, I didn't know I was doing something wrong. I've just tried to use CPAP. I can't use it. I don't get a good response. Why is that my fault? It's really a need for a paradigm shift of a big sort, and it's still not happening. In my book, Life Saving Sleep, I describe all of this and how people can learn to communicate, hopefully more diplomatically than I'm communicating right now, to get across the point that I can't use the device. It's not working for me. And many doctors will say to them, well, there's no other choices. If the patient says, well, what about bilevel? Do you know what the single most common response is? Oh, well, bilevel's no better. Yeah, no, bilevel won't do anything for you. It's the same as CPAP. So I can't change that thinking. A lot of people, you know what they do, as you can expect nowadays? They go out and buy something out of pocket. They say, I just want to try it. I have all kinds of people who come to me for the coaching services. And they go, oh no, I just bought my ASV. I just bought my bilevel. I just found a way to get one. I just couldn't deal with the doctors and the insurance companies anymore. So it was a very big problem. And it doesn't look like it's going away anytime soon, but unfortunately, that's the state of things right now.
So what's the price differential between a standard CPAP and a bilevel?
Most CPAPs can be purchased for between $300 and $800. Most bilevels are between $1,000 and $2,000. An ASV device could be $2,000, $3,000. A lot of these devices, if you keep looking around, you find on these websites that are selling them, and sometimes they'll say never been used, but they're still used. You know what I mean? And stuff like that. And so I saw ones as recently like older ASV devices for $1,500 not that long ago. But a lot of people don't have that kind of money to shell out. and they would like the insurance coverage, although with insurance deductibles, they might be shelling it out anyway.
Yeah, right. Right. You mentioned that the standard CPAP machines cause claustrophobia and they can ramp up anxiety. Is that because of the resistance of the air that it's pushing against your exhale? What's happening there that's causing that?
Two things. One, the thing you just said, that if the pressure doesn't change when you're trying to breathe out,
Hmm.
it feels like you're
Hmm.
suffocating. But then that's a question of like, why would a person have that feeling when I just got through saying 1 out of 3 people do great with CPAP? And
Yeah.
so those people look like what? Well, it turns out they don't have anxiety. So people with anxiety responses have a much lower threshold, and their sensitivity is so high that they feel this sensation, and they
Hmm.
in fact often will focus on the sensation, which then makes the
Yeah.
sensation magnified,
Of
and that is
course.
not easily changed. In
Hmm.
psychology, we call that attention amplification or
Hmm.
somatosensory amplification. And when that happens, a lot easier thing to do is say, well, let me put you on bi-level. And then the person goes, oh, wow, that's really different. I think I can try that. You would think again, you would think it'd be a slam dunk.
Yeah. Is the bi-level the same structure? Like I've seen those
Everything the
CPAPs. Is
same.
it big? It's everything's the
Right.
same?
Right. And there's so many different masks out there now. Now there's the bleep mask, which is this incredible mask that has these little ports that are taped to your nose, and then you just
Hmm.
attach the tubing. No headgear whatsoever. And you can
Okay.
get that at bleepsleep.com. Those are friends of mine. They've been working on this just a few years. It's a great mask. But there's so many masks out there, so many different things. I want to make sure we cover this idea, though, about the nasal breathing, unless you've covered it in other topics where other talks, that people need to understand that right now, tonight, if you think this is your problem, start using nasal strips, use nasal dilators, use nasal sprays. I can't encourage you strongly enough. You've got to start working on the nose because too many people normalize their nasal breathing and think there's nothing to do when in fact there is stuffiness or congestion or a runny nose.
Hmm. Hmm. Um, I uh, I am so dependent on breathing through my nose that if I have any kind of congestion, I'll be up all night. I can't default to the mouth. Like I will just be gasping and I'll be up all night trying to blow my nose. I was told not too long ago that I have a slightly deviated septum. I don't know if that plays into airway, and I'm not trying to turn this into a consult,
Right.
but
Yeah,
you
no,
know,
no, it can, but it's tricky because deviated septums are very confusing. There's a lot of people get the surgery on it and they say nothing changed. There's some people get the surgery and say, "Oh, my life has changed." I mean, it's one of those
those
things.
look horrific too. The videos I've seen of that's a
Uh,
serious procedure, isn't it?
well, it should be taken seriously for the following reason that if you
Yeah.
get a botched deviated septum repair, your breathing is going to get worse and you're going to be really uncomfortable. But it
Mm.
is something that should be looked into because there's no question it can be a part of this nasal breathing paradigm we're talking
Hmm.
about. So I include
Hmm.
that. I have almost all the people I coach or patients I used to see always would have an ear, nose, and throat evaluation. If we were not seeing, really good results to nasal strips, nasal dilators, nasal sprays, that sort of thing.
Yeah. Yeah. So, what's unique about your sleep lab?
Well, my sleep lab was sold to some other doctors about 5 years ago. So, what my sleep lab did at that time that was unique is that we found a way to have this discussion about CPAP and move people onto bi-level devices that were much more effective. The other unique aspect about our center was that despite the fact we call sleep centers, many of them are not equipped to treat insomnia. And
Mhm.
insomnia does have the psychological component too. Even though we've seen dramatic results treating people with sleep disordered breathing and insomnia together. We've also, pioneered a lot of what I'd call more advanced approaches, or maybe a better word would be personally tailored approaches to using techniques for chronic insomnia. In my book, Life-Saving Sleep, more than half the book is about what I would call both cognitive and emotional techniques that are extremely important in how people end up with insomnia and also how to treat it. Because even if you use a PAP machine, there's going to be a subset of people, especially those with fairly severe mental health problems, anxiety, depression, PTSD, where that insomnia still can persist. In fact, the insomnia can be bad enough to make that person have difficulty using a PAP machine. And so when you see that kind of a case, you don't start with a PAP machine. You start with maybe nasal strips, but then you're going to focus on what's called cognitive behavioral therapy for insomnia, sleep-related emotional focus therapy, or even imagery rehearsal therapy. These are 3 different techniques that I've been working on and publishing on for the last several years, either in research articles or in books, describing specific techniques, how people can learn to take their mind and start moving it in a different direction so that they can go to sleep. And if they wake up in the middle of the night, how they can get back to sleep. And this is, of course, without the use of the PAP. Because, just like everybody else, my first inclination about insomnia was it must be a psychological condition. So that was actually good because I got all that training and understanding. And only later did I understand about this physiological aspect. So my books have a great deal of information. In fact, I have a new book coming out in, I think, next month or the month after, called Fast Asleep, which is a new guide on sleep hygiene. And it's called actually a guide for advanced sleep hygiene because sleep hygiene is often administered in ways that are too helter-skelter and don't really help people. In fact, sometimes make sleep worse.
This is fantastic. I mean, I'm fascinated by our conversation, Barry. I know a podcast is going well when I have all these points I want to touch on, and we haven't even gotten to that yet. And we're almost out of time. We still have some time, and I hope you can still hang in there with us for a bit. Now, one of the questions I did want to ask you, and you already touched on this earlier on when we started the discussion, was you noticed changes in the brain. So talk about how poor sleep quality actually damages the brain.
Perfect question. Exactly what I want to talk about next. What most people need to hear, and sometimes is the question, this is a great way that we're segueing this, because when I'm about to say most people can't handle, they don't want to hear this. And I understand that, and I've tried to say it very diplomatically and very gently over the years, trying to learn ways to get it across to people. And I've reached a point now in my career and in my, contacts with people that I'm beginning to realize that we just have to say this and get it out there up front so that people understand that when you don't sleep well, you are causing brain damage. Period. End of sentence. There's no question about it. And I think it's fascinating that just 2 weeks ago, major researchers even showed how a sleeping pill actually aggravates the process I'm going to tell you about in a minute that's supposed to clean up your brain so you don't get brain damage. Sleeping pills actually stop your brainwashing system from working. So that means a sleeping pill is now thought to be a risk for brain damage and possibly dementia.
Wow.
So inside your brain, there's a special washing unit called the glymphatic system. And just like any other part of your body, you develop waste products in all parts of your body that have to be eventually drained away through the lymphatic system or other parts of the circulatory system, and eventually released through the liver, kidneys, into the urine, and so forth.
Mm-hmm.
So when that's not working right, then that means you're not washing and cleaning your brain, and you're going to be suffering brain damage. And in fact, when you have a sleep breathing disorder, or if you have really bad insomnia and lots of hyperarousal and you can't really get deep sleep, again, that system won't work and you're going to get brain damage. So people think, well, it's just sleep. Come on, man. What are we talking about?
Yeah.
It's just sleep. Why such a big deal? Well, if you don't care about brain damage, you're right. Don't worry about it. And there'll be people say, well, I know somebody who slept, they were lucid until they were 90 and they drank and they smoked. Absolutely. There's all kinds of people, different genetic makeup.
Yeah.
I'm not telling anybody what they have to do. Here's the information. We now know conclusively, if you don't sleep well, you are suffering brain damage. And how are you going to know that? Just look at what happens to you cognitively. Because people begin to see things, especially after the age of 30 or 40 at the latest, they begin to see memory changes, concentration, attention, and then what do they go? Oh, I'm getting older. No, you're not getting older. You're getting brain damage from what's going on in your brain when you are short-circuiting your sleep, either through insomnia or self-inflicted sleep deprivation, or more commonly, there's something wrong with the quality of your sleep. And that's the big one. Most people don't step back to ask themselves the question, what is the quality of my sleep? As you know, in this book, it just starts out with all about sleep quality.
Mm-hmm.
Sleep quality is everything. You've got to be able to ask yourself, when I woke up in the morning, did I feel great? Did I jump out of bed? Did I jump into the shower and start singing? Did I did I come out of the shower and start thinking about what am I going to accomplish today? And all without drinking a cup of coffee. That's normal sleep, by the way, what I just described. If you're
Regardless of duration?
Well, duration is a factor, but it's highly overrated in that people waste far too much time thinking about how many hours I need and not enough time thinking about what's my quality like. You've got to be able to figure out your quality first. Anybody who figures out the quality of their sleep, problems, mild, moderate, severe, whatever, when they figure out the quality, they're going to go, oh, this is a bigger deal. And then when they treat their quality, the fascinating thing is they're going to find out what the number of hours of sleep is supposed to be. People who fix their sleep quality in a hurry with some really great devices, let's say PAP machines, cognitive behavioral therapy for insomnia, whatever the techniques are that finally puts it all together for them,
Yeah.
many of those people will sleep longer. Why? Because they're catching up, okay? But over time, some of those people will start sleeping shorter. And they're going, gosh, I thought I needed 8 hours of sleep. But now I'm only sleeping like 7 hours and 20 minutes, and I feel great. And I go through the day and I feel great. Do I really need 8? No, of course not. You've normalized your sleep quality, and so your body is doing what it's supposed to do.
That's fascinating.
That's what normal sleepers do. So if you ever meet a normal sleeper, and they're not many, the true number of normal sleepers is probably only 1 out of 10 or 2 out of 10 at the most, would be my guess. Somewhere in that range. I could be low. I'm not sure, not certain, but I've not met many. I'm biased, of course. I'm a sleep doctor, so I'm going to meet more people that have problems.
Right.
But normal sleepers tell you that. They get into bed, they go to sleep, they wake up, they feel great. Just repeat that cycle over and over again. The numbers could be 7, 6, 8, 9, 6.5, 7.5. Normal sleepers.
That's fascinating. So obviously, if you wake up refreshed, that's one simple gauge to know you got enough sleep. If you wake up motivated, really, and that's I've noticed for me personally, 6 hours is good most of the time if I can accomplish that. If I get under 6, I'm definitely not optimal. But if I hit that 6 hour mark, I feel refreshed. I'm ready to go. I can sense it. I'm ready. I'm ready to start my day. But obviously, it's individual for different people.
Absolutely. And it also depends on the great masking that occurs through caffeine. So there's lots of people who describe what you just said, but then it turns out that in the middle of the day, they must, I'm not saying they shouldn't, they must use caffeine to continue in that vein. And that's the way they've adopted that lifestyle. And if that's the lifestyle they like, more power to them. But eventually, they want to clarify what else is going on. What if they have high blood pressure? Do they know that's directly related to their sleep? What if they start to see concentration, attention, memory issues, and they go, the caffeine is helping, but it's not helping as much as it used to. Again, another red flag.
Yeah.
Lots of
It's a
people,
Band-Aid, right?
yeah, well, it's a much better than a Band-Aid because caffeine is probably the most life-saving drug the world has ever seen. It's probably treated more cases of mild depression in the history of civilization. It's probably saved more lives of workplace accidents. So caffeine is a fantastic drug, but on an individual basis, you want to ask yourself, how is it working for me? What is it doing for me? And what might it be masking that is not such a good thing that I need to investigate?
Barry, we're running out of time here. I hate to say, but I would really love to have you back and do some more discussions on the work you're doing and just going through your book. And I hope you'd join us again.
Sure thing.
How can people get more familiar with who you are?
Well, thanks for the opportunity for the discussion. I thought we had some good back and forth there. I'm glad you brought up some of your personal stuff because I think that's always very helpful. That's why I bring up my personal sleep stuff as well. My website, barrykrakowmd.com, has a section on it for my sleep health, sleep health coaching. It also has some other books and videos some are free, some are for sale. I also have a newsletter called fastasleep.substack.com. And I have the new life-saving sleep book out. And as I mentioned, the new book, Fast Asleep, will be out shortly.
Great. We really look forward to having you back, Barry. Thanks for being here.
Thank you very much, Mike.
That'll do it for this edition. We are out of here. Drop us a comment. Let us know, what is your sleep like? Have you struggled with sleep? Do you struggle with insomnia? Do you sleep well? What do you do to get to sleep if you can't sleep? We love hearing from you guys, so drop us a comment, give us some feedback on that, and always check us out at Mikeseapodcast.com. And if you haven't clicked that subscribe button or that like button, help out the algorithm, help us out, and help support the content if you like what we're bringing you. We're out of here until next time. Thanks, everybody.